It's my immense pleasure to welcome one more eminent speaker, Dr. Madhusudan Upadhya. Sir is Professor and Head Department of Emergency Medicine at Kasturba Medical College, Mangalore. His special interests include obstetric anesthesia, difficult airway and safety. He has over 65 publications to his credit. At present, he is the editorial member of IJA. He was the editor of Karnataka Anesthesia Journal from 2001 to 2006. And he is also an editor in Obstetric Anesthesia Journal and South Zone Supplement of IJA. Previously, he was Secretary and President of ISA State Karnataka Branch. Sir was Organizing Secretary, Chairman in various conferences before. Over to you, sir.
Thank you very much for having the patience to go through that. Yeah, thank you so much. How do I get to the first slide? First, I would like to thank the organizers for having gotten me here for the lecture on a CME day. Thanks to Manju and the others. It's also a pleasant task to deliver a lecture in front of Dr. Usha Madam. Our association goes back to maybe the year 2001 when they organized the South Zone Conference, which was given to us actually, and I wasn't in a position because the previous year I had done the state conference and we offered it to Mysore, and that was when Madam was the organizing secretary. And nice to see you again, ma'am, here. It's really a pleasure. Yeah, coming to the topic, anemia in pregnancy. Whenever the class schedule is put up in the department, when there is a GC on anemia in pregnancy, I usually take the person who has put the schedule to task, because anemia in pregnancy per se is not an anesthesia topic. It's a topic for obstetricians, topic for a hematologist. Anesthesiologist has a minimalistic role to play when it comes to managing a patient with anemia. Same as with any other patient who comes with anemia to you, right? Therefore, this is going to be a hematology lecture and maybe a couple of slides on what is the role of an anesthesiologist. Therefore, bear with me. But since you are going to anesthetize patients with anemia, it helps you to revise and be prepared whenever you have this kind of a patient on table. A lot of things I'm going to cover if the time permits. How do you diagnose? What is the effect of anemia on the mother and the fetus? Signs and symptoms in pregnancy. How do you prevent anemia? And the supplementation of or the therapy of anemia during pregnancy and labor and delivery management, as I said, is a small part of my lecture. And a slide on National Anemia Control Program and then postpartum contraception. I don't know how much I can cover. Yeah, as you are aware, it's the commonest medical disorder in pregnancy, and in India, it is as high as 50 to 70% of your pregnant women come to you with anemia. By definition, anemia is 11 grams of hemoglobin or lower, and obviously, most of our Indian women are anemic. Whether it is a corporate setup or a government setup, the women are anemic because they don't take care of themselves. And the US, it's about 2 to 4% is the prevalence, in spite of the reasons we know are beyond our control too. Nutritional anemia or the iron deficiency anemia is the most common one, and important contributor is basically to maternal and perinatal mortality and morbidity is anemia. Could be a direct or an indirect cause. As I said, the diagnosis basically is, the definition is basically for a non-pregnant woman, hemoglobin of less than 12 grams % is anemia. But for pregnant women, it's 11 grams or a hematocrit of 33%. And ICMR says that mild anemia is when the hemoglobin is anywhere between 10 and 10.9 grams %. And moderate is 7 to 9.9, and severe is less than 7, very severe is less than 4. But generally you don't consider the very severe part of it, and severe is 7 grams percent or lower is severe. What could be the causes? Obviously we will focus on only the top three, the nutritional or the iron deficiency anemia, pre-pregnancy poor nutrition, and then folate and B12 deficiency, which also can cause anemia. All the others, they do contribute to anemia during pregnancy, but they're also there in life. And in India, obviously, these issues could be a possibility, the multiple pregnancy, multiparity, and then very frequent pregnancies, they also can contribute. But the rest of them, including the aplastic anemia, are the last one on the list. And what are the three main causes? They are basically the reduced erythrocyte production, hypoproliferative anemia, which is iron deficiency, and folate and vitamin B12 deficiency. You can have RBC destruction due to various infections and parasitic or otherwise, and then there can be bleeding, and it causes anemia too. 90% of anemia in pregnancy is due to iron deficiency in India and other developing countries. Just to give you a perspective, it is not a unknown thing or a rare thing to have anemia. About 2 billion of the world's population are anemic, and 29% of the non-pregnant women and 38% of the pregnant women are anemic. Anemia is a pandemic. What are the causes for anemia? We just discussed physiological changes of pregnancy does cause anemia, and the plasma volume, as you are aware, increases by 50%, but the RBCs don't match up, therefore there is anemia. But there is no change in MCV or MCH, therefore there is no point in doing all the indices, but the patient is still anemic. The iron requirement goes up by about 2 to 3 times, and folate requirement goes up by about 10 to 20%. Therefore, 10 to 20 times. Therefore, the patients are bound to be anemic. All right. The common types, we have already looked at them, but again, worth repeating them: nutritional deficiencies, iron, folate, and B12 deficiency, and hemoglobinopathies like sickle cell disease or thalassemia. But these things are, as I said, are quite rare. You need not worry much. They either would have been managed otherwise, or they wouldn't conceive and come to you with those diseases. What is the pathophysiology? Again, we have just discussed, and then it's also a possibility that the iron stores are depleted with each pregnancy, and too soon and too many pregnancies result in higher prevalence of iron deficiency anemia. As I said, it's a bane of any of the developing country. Pregnant woman requires much more iron than all of us need. They need about 800 to 1000 milligrams extra iron, though they do save about 400 milligrams during the pregnancy because they don't lose because of menstruation, and then there is contraction of blood volume at the time of delivery, but still they do need the extra iron, which has to be supplemented, otherwise they go anemic, as I said. What are the things they need to produce hemoglobin? They need the proteins, they need the mineral in the form of iron, they need the hormones like erythropoietin, thyroxine or androgens, they need the trace elements, and they also need vitamins. Kind of all of the vitamins, B12, folic acid, vitamin C, pyridoxine, vitamin A, everything is needed to produce an RBC or for erythropoiesis. Therefore, everything has to be, the mother has to receive almost all of this when she is pregnant. And we also need to supplement a lot of iron. As I said, the absorption is quite low, therefore you have to supplement much more. And in late pregnancy, you need about 6 to 7 milligrams per day, and the daily supplement of 40 to 60 milligrams of elemental iron is mandatory. And you also add, as I said, the other two, the B12 and folic acid. How do they present to you when the laboring woman is anemic, or even otherwise the woman is anemic? Depends on the severity, obviously, and the people with adolescent, pregnant, and multiple pregnancies, lower socioeconomic status, they are at high risk, and you should consider them. Clinical presentation, I don't think I have to tell you every bit of it. They come with pallor, facial puffiness, glossitis, stomatitis, chelosis, and brittle hair. And they also have raised JVP, tachycardia, tachypnea, all this, hemic murmurs, cardiac failures, if at all they have severe anemia. And couple of slides on what happens to the mother and the fetus. The higher incidence of pregnancy complications are common with anemia, preeclampsia, abruptio placentae, or preterm labor, and they are more predisposed to infections like urinary tract infection and puerperal sepsis. There is an increased incidence of postpartum hemorrhage. There can be subinvolution of uterus, lactation failure, and then the maternal mortality can be due to congestive heart failure, cerebral anoxia, sepsis, and thromboembolism. Can anemia be deadly? Obviously, it is. In a country which has still millions and millions of BPL card holders. Effect of anemia on the fetus is there could be a higher incidence of abortions, preterm birth, or IUGR. There can be IUDs, low Apgars, the obtunded babies, and neonate is more susceptible for anemia because the stores the baby comes out to the earth is much lesser, and higher perinatal morbidity and mortality, and the baby can have cognitive and affective dysfunction. For it is mandatory that when the fetus in situ, the hemoglobin has to be maintained at all times and at all costs. The fetus can have, as I said, anemia because of the poor stores, and then there is increased risk of perinatal morbidity and mortality. And the most critical period for the mother is 28 to 30 weeks of pregnancy, when you need a lot of iron and folate for the baby to grow physically and the cerebral growth. And when the mother is in labor, when she can bleed and bleed above normal, and immediately after delivery, again the same issues, and early puerperium because of infections too. What do? You obviously take a detailed history and you look for the causes which could have led to anemia, not only nutritional and everything else too. Examination, again, as I have already told you, what are the things to look for, and you have to look for them. And then you have to investigate them. And severity of anemia is determined by the hemoglobin and hematocrit at the first visit, at 28 to 30 weeks, and then again at 36 weeks. You have to know the type of anemia, whatever peripheral smear onwards, whatever investigations you need to do, you can do. Then if still you haven't been able to find the cause, do a bone marrow invasive bone marrow biopsy, and that will tell you mostly what could be the cause for the anemia. There is no point in doing the red cell indices, I had already told you. Only the RBC count decreases, and the rest of the things, unless there is iron deficiency anemia, it may not change much if it is only normal physiological anemia. If nutritional, obviously, these are the things which will indicate to you whether the patient has nutritional anemia. These are the special investigations which you may or may not need to do if you have already known that the patient has nutritional anemia. But it's worth doing all these things because it will also give you a lead to what exactly the patient is suffering from. You have to look for do the urine investigations, examination for the RBCs and casts in the urine, stool to rule out occult blood or ova, bone marrow, as I said, whenever the patient has refractory anemia, X-ray chest to look for the other causes of tuberculosis or infections, and then renal diseases also can lead to anemia in pregnancy or otherwise. How do you manage them? You have to obviously look at improving the diet and treat the worm infections, food fortification. Generally, the Anganwadis provide with fortified rice also to the patients when they come in. Rice fortification is something which has been taken up on a war footing. I told you Anaemia Mukt Bharat is 6 into 6 into 6 strategy. You can, at leisure, you can go through this. Heme iron is better and the better source is the meat, but it doesn't preclude the vegetarians from having good hemoglobin. I'm a testimony to that. And you avoid tea, coffee, calcium phytates, phosphates, oxalates, egg or cereals with iron because iron is chelated and the absorption does not happen. Therefore, you have to avoid that. All right. Iron-rich foods, obviously, there are vegetables, there are fruits, and then there is meat. You can ask your patient to take any of this. And supplementation, I have already spoken about the supplementation, and it has to be avoided in the first trimester. Obviously, we don't give anything in the first trimester, and then you have to go on with the second trimester onwards. All right. And oral iron, you have to look at whether the patient tolerates the oral iron. If the patient does not tolerate, obviously, you have to change over to the parenteral ones. But otherwise, this is the best way forward, the oral iron. But as I said, there is contraindication. And when the patient starts to feel better, and when there is improved look of the patient has better appetite and rise in hemoglobin by about 0.5 to 0.7 grams per deciliter, and there is reticulocytosis, the patient is responsive, and then you need not change over to parenteral iron. Parenteral iron also has its own drawbacks, but when you calculate, you have to calculate the weight in kg and iron deficit into 2.2, and you also add 1000 milligrams for the iron stores to build up in the mother. When do you look at blood transfusion? If your obstetrician says my patient's hemoglobin is not going up, would you advise? Yeah. Obviously, when the patient still presents to you with severe anemia and you see it only at 36 weeks and the patient is almost ready for the delivery, I think you have to go for blood transfusion. If there is acute blood loss either because of APH or PPH, if there is associated infections where your conservative methods may not help the patient much, if the patient does not respond to oral or parenteral therapy, and then anemic and symptomatic pregnant women, when they have dyspnea or with heart failure, irrespective of the gestational age, you give the blood transfusion, right? Couple of slides on what you should be doing when the mother is in labor. Labor should be supervised, obviously. There should be proper counseling and consent to be taken for even the blood transfusion. The anemic patients, they do bleed a little more than normally pregnant women. Therefore, you have to make sure that the blood is kept ready, at least cross-matched and ready. And woman has to be nursed in a propped up position and better give oxygen if the patient is anemic. You have to be extra cautious when it comes to doing the pervaginal examinations and introduction of infection to the mother. And prophylactic antibiotic is not a bad idea when the patient is going through normal labor too. You have patent IV line, but don't give any fluids because the patient is already hypervolemic and anemic. There is no point in giving more fluids and then make the patient, another 2 minutes. And if the patient is decompensated, you use diuretics. Second stage, you can use forceps or you can use a vacuum and get the baby out faster. You can shorten the second stage. And third stage has to be managed with oxytocin or misoprostol. Ergometrin is never used because of, I don't know whether unless you have impending PPH or PPH has already set in, Otherwise, methyl ergometrin I don't think is a routine drug to be used in delivery time. Even normal blood loss may not be tolerated well in anemic patients, and therefore you have to be cautious and you have to transfuse blood. Early ambulation is encouraged, and hematinics are continued for 3 to 6 minutes, and avoid pregnancy at least for 2 years, and then you have to advise all these lactation amenorrhea or progesterone only pills or IUCDs or permanent sterilizations. That is the role of an anesthesiologist when it comes to managing the anesthesia. With the permission of the chair, since this is CME, I got a few questions. I expect only the postgraduates to answer, right? And everything has been covered over the last 25 minutes, therefore nothing out of syllabus right now. Pregnant woman is considered anemic when the hemoglobin is below. No chocolates, no, unless they want to give chocolates to the right answers. 11 grams, right? We'll take that. Most common cause of anemia in pregnancy in India is nutritional anemia. Iron deficiency anemia can be diagnosed earliest by which laboratory test? I know everybody says it's hemoglobin. Now, ferritin? Acceptable. Okay. There are so many indices which can be done actually, but amongst these 4, I think you can take it as ferritin. Even serum iron is not a bad option. Response to anemia management by oral iron therapy in pregnancy can be assessed earliest by increase in hemoglobin or reticulocyte count? Reticulocyte count, because bone marrow has to respond first, right? Yeah, agreed. Which complication is not common in anemia of pregnancy? It's obvious. Hypertensive disorders, possible. Preterm labor, yes, possible. Sepsis is possible. Therefore, GDM is not a possibility. Thank you very much for the patient hearing. And anemia, we have, this is what I said. No, I'm done. Thank you very much.